Good morning. I assume it's morning. I usually give this presentation in the morning, and I assume it's the same today. Um, my name is George White. I'm an occupational medicine physician here in Williston, Vermont, and I'm going to be speaking about the independent medical examination and impairment rating. So first, before we get started, it's always helpful, I think, to define our terms and so that we all are talking about the same thing. And this quote's been attributed to Voltaire. I'm not sure if he really said that, but it's a pretty good starting point. So first of all, what is an independent medical examination? And this is a definition from the American Board of Independent Medical Examiners. And it's an evaluation performed by an evaluator who is not involved in the care of the examinee. And that's important. It's an independent set of eyes. It's someone who is not taking care of the patient and doesn't plan to begin taking care of the patient. And the purpose is to clarify clinical issues and case issues. And we'll talk a little bit more about that. An impairment evaluation is a little different, but often part of an independent medical examination. And this is an examination which is carried out in order to determine a permanent impairment associated with a medical condition. And this can include an impairment rating, such as that provided in the AME guides. And it points out here, impairment evaluations are performed by a licensed physician. Some treating physicians do perform impairment ratings. There's debate about that. Some physicians who do treat patients don't feel it's appropriate. Other physicians, in my experience, have suggested that that's the only person that should be doing an impairment evaluation because of the greater knowledge of the individual, but that's something that folks can debate at their leisure. This is an important definition and differentiation: impairment versus disability. A lot of times I'm asked to provide a disability rating. I am not aware of any disability rating, at least not here in the state of Vermont. What we do is an impairment rating. And according to the AMA guides, an impairment is a loss of use or derangement of a body part, an organ system, an organ function. It's a physical, anatomic, physiologic thing that you can hopefully measure to some degree. Disability, on the other hand, is an alteration of the individual's capacity to meet personal, social, or occupational demands, etc. You can read that as well as I can. It's a relational outcome. And what I mean by that is the disability is related to the environment in which the individual lives, while an impairment does not have any relevance to that, but is simply a loss of use or derangement of a body part. It doesn't matter what that individual does for a living or a hobby or what have you. Whereas disability does have relevance to those issues. Usually at this point, I'll ask questions or make sure people are following. I hope that this is that I'm making this clear. So when we start out to do independent medical examination or an impairment rating, I look at it as a four-part process. There's review of the medical records that are available. There's a history, taking the history from the individual. There's a physical examination, and then generating a report to address the questions that are posed. So first, I usually start out with a record review. Usually I have the records ahead of time. That's very helpful. And the medical records that are received can include a lot of different things. Often there's an employer first report of injury, sometimes not. That's helpful if it's timely. Occasionally you see these that are done months after the injury, and that's not as helpful, I don't think. There's medical office notes from physicians, nurse practitioners, PAs, anyone that's been treating the individual. There's procedure reports, injections, various diagnostic tests, things of that nature. Surgical reports if the individual's had surgery. For certain types of impairments, those are crucial because certain operations actually affect the impairment regardless of what other physical findings there are. The type of surgery itself might carry an impairment component. I'll come back to that a little bit. There's physical therapy reports interpretations by radiologists of diagnostic imaging. Once in a while, surveillance reports or videos, observations that are random observations ad lib of the individual living their life. So the records come in various forms. Hopefully now most people now are moving over to a paperless system, and I hope that continues to eliminate all these piles of paper. Well, the camera's not showing, but behind me I have these boxes and boxes of paper that I've got to take to the shredder that I haven't taken over there yet because of the COVID and all that. They were closed, yada yada. So I have these mountains of paper that fill up these boxes. And of this voluminous chart, narrow it down to probably maybe an inch or so that's actually relevant medical information. You can see how enthusiastic I am about reading those records. Sometimes records come on a CD. That's better than paper, or DVD, CD, whatever. That's better than paper. Sometimes a PDF attached to an email. And I know some people have issues about the confidentiality and will use a different format, like a Dropbox type of thing. But generally a PDF online. I think that's the best from my perspective. There's no paper involved, and it's easy to read. And it doesn't have to go in a box over to the shredding company. And it doesn't kill a lot of trees, so that's always nice. Oh, one other thing, I have this monitor that's a vertical monitor. This is great because most monitors, they seem to be designed to watch movies, widescreen movies or something like that. If you're looking at documents, you want a tall monitor like this, and it's a big monitor that's really nice for, especially as you get older, your eyes aren't as good. For looking at documents that are taller than they are wide. You don't see many of those, though. There's only a couple of companies, I think, that make them. So we've read the records, we've looked at all the records and kind of got an idea of what's been going on with that individual. And this guy, Osler, he was a famous, one of the giants of medicine, late 19th, early 20th century. He's Canadian, one of the founders of Johns Hopkins Hospital, and great medical educator. And he said, listen to your patient. He is telling you the diagnosis. Well, at this point, the diagnosis in most cases is we already know what it is, because the person was seeing has been in a year, maybe more, through the mill and has had every test there is and so on. And it's making a diagnosis isn't the primary issue in an independent medical exam. One other thing I will point out at this time, though, he says, listen to your patient. And I should have mentioned when we're looking at definitions, in doing an independent medical examination, we're not seeing a patient. We use the term examinee because patient is a term that has ramifications of treatment, patient-physician relationship, things like that. We're seeing an independent individual as an independent examiner. It's not our patient, so we use the term examinee. We're not going to get involved in their treatment. We're just going to make an opinion about whatever questions have been raised. There's a variety of elements of the history. So I do a sort of face-to-face history conversation, the traditional thing that I learned in medical school and later. And so typically there's initially a problem statement or a chief complaint. The person say, what brings you here today? Back pain, neck pain, tingling in my hand, whatever it is. That would be the chief complaint. We look over what other pre-existing problems. Is this something brand new? Is this something that's been going on for a while? Have you had this before? Yada, yada. What's the history of the injury? Did you have a fall, or did you just wake up one morning and it hurt and you said, oh, gee, it must have been that thing I was doing yesterday? Then a chronology. What happened? All right, so you had this injury. What happened then? Going through hopefully from the moment of the incident until the time that the person is sitting there at the desk here. And some folks are happy to give voluminous details. Other people are taciturn and say, I hurt my back, I had surgery. Now they say I have to come here. And try to elucidate as much as I can, but typically a lot of it is already established from the medical records, but I like to know what the person's own impression is of what's been going on and what they've been told and things like that. Oops. And then current status. How are you doing now? What's the situation? How are you? Are you all better? Are you still having problems? Are you worse? Functional status I separate that out from work status. Functional status, just day-to-day life, what kind of things you do, how do you spend it every day, are you working, do you have hobbies, are you able to do all these various things, are there limitations that you have because of this issue. Sometimes social history comes into this as well. I put that separate here, but often it'll be just included in the functional status. Occupational history, whatever's relevant, where do you work? What kind of work do you do? Are you working now? Uh, past employment, things like that. And as I mentioned, social history not as critical most of the time, but and more included in the functional status. Past medical history, is this a new thing? Do you have some history of illness? Did you have diabetes, which can wreak havoc on a variety of organ systems and create issues for recovery? Family history is I don't find that typically as important. In this setting, usually once in a while, if there's some really significant risk of a genetic disorder. Review of systems, again, that's typically not a huge part of doing an independent medical exam for someone with a musculoskeletal injury. Now, there are a variety of questionnaires, and I don't use a lot of questionnaires, at least when I'm using the 5th edition of the AMA guides. For certain cases, federal cases, and one or two states that use the 6th edition, then there's questionnaires that are used. But I go through a few of them. There's a pain disability questionnaire, the so-called PDQ, and this is about pain-related disability. Pain, generalized pain, wherever your pain is. This is the questionnaire that's used, and it gives a score that can relate how disabled one is by pain. I think these questionnaires are useful in tracking progress as you treat someone. If you're in a treating practice, looking at those questionnaires from time to time and watching the change. The Oswestry questionnaire is a similar thing, only it's about specifically back pain. So this is a disability-related, back pain-related disability questionnaire. There's a questionnaire for the arm, shoulder, and hand, the DASH. And there's a similar one for the leg, lower limb. And that's looking at disabilities related to lower limb problems. Now, at this point, I generally ask folks, do you find these really helpful to have included in the report? Because as I mentioned, I don't use them a lot, once in a while. I'm not sure how useful they are in the context of a typical independent medical exam, unless using the 6th edition where they do come into play. But with the 5th edition, if it's an impairment rating, 5th edition impairment rating, I don't use a lot of these, and I look for a show of hands. Nobody really, maybe one person or two persons over the years I've been doing this, have raised their hand and said, yeah, I'd like to see those in there. I don't use them a lot. Send me an email if you think they really, really are useful to you. So we've talked with the individual, the examinee. I'm not going to say patient. We've talked with the patient. We've read the records. And now we do a physical examination. And the purpose of the physical examination is a number of things: to support or refute the diagnosis. So we kind of already have a diagnosis most of the time. And typically, we're not going to come up with a whole new diagnosis. Once in a while, in cases that are more recent, but when someone's been 2 years through the mill and they've seen every specialist in town and out of town, down in Dartmouth or somewhere, the likelihood I'm going to come up with a new diagnosis that all these people missed, I confess, is not very large. And we're also going to measure impairment during the physical examination if it's an impairment rating issue. And there might be some ability to prognosticate, to figure out, what's really going to happen to this person. How's things going to go in the future? And we can test these Waddle signs that folks are often very interested in. We'll come to that a little bit. So there's a variety of equipment that's used in examining individuals, examining patients or examinees. And it's a funny thing, because when I was in regular clinical practice, the ones I used the most, I used the stethoscope, of course, and the sphygmomanometer, blood pressure thing, otoscope, and the ophthalmoscope, those. And now I hardly ever touch those. So now what we use is a goniometer, and there's one goniometer there. I also had this really long one, this big long goniometer for measuring various angles of joints, hips and knees and so on. And there's this gadget, which I never owned one of these until I started doing the impairment rating. And most people don't even have one of these because you're going to use it for impairment rating pretty much. And this is a dual inclinometer, so I got one right here, and it what it does is it measures angles, and I'll show a picture of that, how it works in practice. And those are the things, and of course reflex hammer, those are the things that are used the most. There's also the 2-point discriminator type of gadgets. There's one. This picture is one of them. So actually, here it is here. But there's also one that's quick and convenient because it has the points already set. Whereas this one, you gotta let's see, you gotta open it to the where it's measured on there to get your 2 points. This one has the 2 points already measured, almost like I don't know, measuring a spark plug gap or something. You got your points all set the way they're supposed to be. Got to clean all this stuff with wipes nowadays because with COVID and so on. But there's nothing that penetrates the skin. Oh, there's also these things. No, testing sensation in a regular clinical practice. I don't know if you really need something like this, but these are little. You hear about these monofilaments. These are so-called Sams-Weinstein monofilaments, and they go from this really fine thread that you can barely see on there, like probably a 10x trout leader or something, and then it goes all the way up to this stiff piece of plastic for testing digital sensation, the fingers, and those come into play in certain impairments for digital nerve injuries, those kinds of things. So those are some of the little tools that are used. So the physical examination really starts as soon as you see the person coming down the hall. And I have about 75 feet from my door of my office over there all the way to the waiting room. It's our waiting room over here. And so I get a chance to observe gait as the person comes up to the door. And then when they're leaving, get to observe the gait as they go back, down the hall. And first impressions are important in medicine as well as in social life, I guess. And so when you see this, that's a bad sign. You're going to be a while. So you're making some initial clinical impressions immediately upon seeing the individual. Here's that gadget. So what it does is, so when you read these reports, it says using the dual inclinometer. So you got one when you bend your neck forward, it's going to be pretty hard, or your lower back or thoracic spine, whichever. You're going to bend. It's going to be hard to bend just your neck and not move your chest or move your hips, depending on which part you're measuring. So what this does is, you got one point here on the bottom of the neck, or really the top of the thoracic spine, and then you have one here on top of the head. And as the person bends forward, you see there's a measurement here showing up. I can't read it. 32, I guess it looks like. And then this one, though, this is subtracting any motion that's coming from the thoracic spine, so or the lumbar spine. So in effect, this person could bend all the way down and touch her toes, and we would still get only the measurement that's happening of motion that's happening in the neck. So that's for certain spine impairments where you need to know range of motion. Obviously, in a clinical setting, if you're treating patients and you want to know how their movement is, this is a little bit of overkill. But for impairment rating in the 5th edition, for a certain subset of spine problems, you do need to use this. Though the 6th edition now has kind of done away with it. You don't really need that because they realize that range of motion as a marker for impairment is pretty debatable, put it that way. So one other thing you find out in these physical exams is these so-called Waddle signs, and people want to. Sometimes they'll even say in the questions, are there any Waddle signs? And Gordon Waddle is a Scottish orthopedic surgeon who came up with the Waddle signs in 1976, or actually 1980, excuse me. And it's signs of non-physiologic reaction or non-anatomic or non-organic signs that suggest that there's significant say, psychological um, component to the individual's problem. One of the problems with this is that folks jumped on it and says, "Oh, this is a sign of malingering," and it's not. And I think Waddle spent a whole bunch of time trying to explain to people this is not about malingering. It's just about the strength of the psychological or the supratentorial, if you want to use that expression, role in the individual's problem. And when we have an injury or an illness, all of us have some psychological reaction to that. I don't think anybody, except maybe Mr. Spock, aren't going to have some kind of psychological involvement in a medical case or an injury or something like that. These tests basically tell you, is this a person who's going to need some significant psychological interaction in the course of their care? And so there's a variety of, there's 7 signs in 4 categories. So there's tenderness, superficial tenderness, where you just touch the person, and it hurts, and non-anatomic tenderness that's in a location that doesn't make any sense based on the diagnosis. There's some simulation things. I'll show those. I have a picture of those. There's some distraction. I have a picture of that. And there's some regional things like weakness. If you have a S1, let's say S1 radiculopathy, you're going to have pretty localized weakness in a certain part of your leg. But if you have, say, generalized weakness all over the leg, and that kind of doesn't make anatomic sense, or sensory disturbances that don't correlate with, your EMG or your MRI or whatever it might be, your diagnosis. So things that are kind of not really concordant with what you know physiologically and anatomically will constitute these so-called Waddle signs or non-organic signs. I don't think Waddle himself ever calls them that, but anyway. So here's some simulation. So what I'm doing here, this person was low. By the way, I should point out, these are for low back pain. Or other people have come up with non-organic signs for other parts of the body, the neck and the shoulder and so on. But Waddle's paper was validated for low back pain. So here I'm pushing very, very gently on the top of the person's head, and she's having this awful, basically just enough to push the hair down to touch the scalp, more or less. And then the person's, oh, that's terrible hurting pain in the lower back. Well, that doesn't really correlate anatomically. So that's one of the so-called simulation Waddle signs. Now here's another one. So we're doing rotation. And so we're going to rotate the whole body as a unit. So there's no motion at the spine, but the whole body is turning. And then that's causing this terrible pain in the lower back. Again, there's no movement going on at the spine. Kind of gives you a I wouldn't say suspicion, that's a loaded term. Food for thought. Okay, something to think about. Oh, and by the way, a lot of folks will have 1 or 2 of these, and it's when you got a large number of these signs all positive that you start to really be concerned. So this is distraction. Now, straight leg raising is a time-honored test for radiculopathy in the lower extremities, particularly L5, S1, and L4, 5 maybe to a degree, to a lesser degree, but L5, S1 for sure. And so when we do straight leg raising, what we're trying to do is achieve hip flexion of 90 degrees, and a straight knee. So here I'm looking at, oh, those are nice shoes. Where'd you get those? You get a big smile. It's no problem. We have a hip at 90 degrees. We got a straight leg, straight knee, and no pain shooting down the leg. So this is a negative straight leg raising. Seated straight leg raising, which is a valid diagnostic test. So we have negative straight leg raising. Well, then we go in the supine position and we say, oh, tell me if this hurt you when I raise up this leg. And we start bringing the leg up in this, terrible pain, back pain, or pain shooting down the leg. But look, we only have a few degrees of hip flexion. It's that's not an anatomic correlation here. Oh, and by the way, people talk about straight leg raising positive, and this is true not only just doing these kind of exams, but in medicine in general. When people put in a chart in a medical record, straight leg raising is positive, it's helpful to know what do they really mean by that, because a true positive straight leg raising test, whether you're doing it seated or supine, is pain that goes down the leg in a distribution that you'd expect, based on their nerve, nerve root impingement. But sometimes people say, positive straight leg raising. You're looking at what they really found is that it hurts the back. Well, a back pain with straight leg raising is not a positive straight leg raising. So it's probably better to be precise and say, at X degrees of straight leg raising, there was pain shooting down the leg. Then you can hang your hat on that a little bit more. Okay, editorial's over. Okay. So we've had history, we've had record review, we've had a physical examination. Now sometimes they send medical, I see medical or diagnostic imaging. And I'm not a radiologist. I do like to look at the x-rays and images and stuff. Some I'm more comfortable with than others. I'm pretty comfortable with spine, but not maybe shoulder MRIs. Well, that's not, well, anyway, this is a lumbar spine MRI. And just so you'll kind of see what sometimes folks are talking about, if you look at the discs are here, these are the discs, okay? And in between, this is the bones. This is the vertebral bone. This is an image that's shot pretty much as if we slice the person down this way. See, cut down this way, sagittal image, and pretty much right toward the middle of the person. And then we're looking at him from the side. The person's facing toward my left. I don't know if this thing mirrors or what, but it's face this way. The person's facing this way. And so their stomach and all that's going to be over here. And here's their back, the back, okay? So the spinal cord comes down here, and it terminates in a cauda equina, which is a bunch of nerve roots that go on down. Cauda equina means the horse's tail, because it looked like that to the anatomists, I suppose. There's the hard, spinal cord tail part, and then the furs, the hairs, are the nerve roots, and they come on down. Each level of the spine, they go out and they go down the legs. And so in this case, what you see, you see the discs here. They're kind of white or light gray, if you will, light gray. This image is looking for water content. So there's a so-called T2 image looking for water content. So you have water content here, here, here. Oh, but then you look down at these lower two, and they're dark. They're dark. So people say, oh, black disc, the evil black disc. Well, basically what this is telling us is there's less water content, less water in these discs than there is in these up here. And these are the lower two, the ones that are most likely to end up with disc degeneration, which all of us are going to have, of course. And then you can also see some protrusion, disc protrusion here. And when people say, oh, the black disc, the disc isn't black. If you were a surgeon and you cut in there and look at it, it's not black. It's like crab meat or something. But it looks that way to the MRI scan on the T2 image because it's looking for water and has less water. So things where there's less water will be black. Lots of water, spinal fluid and stuff, that'll be white. Fatty tissue too. Anyway, that's a lumbar spine MRI. So this could be a disc that's causing some issues, or maybe not. A lot of times you can go out and drag people in off the street, do MRIs, people that have no back pain, you find all kinds of stuff like this. If you're over a certain age, guarantee you're going to have it. All right, so we've looked at any images that are there, and usually we've had the radiologist reports, and I'll trust them for the most part. Or alternatively, sometimes the orthopedic surgeons will read the MRIs and scans and X-rays and things, and have a different idea of it. And then who's correct? I'm not going to go there, but the orthopedic surgeons have the advantage of actually looking at lots of people inside their real bodies and looking at X-rays. So and images, other images, MRIs and things. So they've developed a way to correlate physical anatomy in person with pictures on a screen. So that might carry some weight. All right, so then we got around to sitting down and writing the report and addressing the questions that folks have posed. And so common questions, well, you guys are the ones writing these questions, I guess, so you know what they are. And so there's the diagnosis, the prognosis, is the treatment reasonable and necessary? Which these two words always seem like it's one word. Reasonable and necessary is always one word. I don't ever see, is this treatment reasonable? Yeah, yes or no. Is this treatment necessary? Yes or no? Because they are really different concepts. But anyway, is there a cause and effect? That's one of the most difficult ones, I think. What's the work capacity and impairment? Is there impairment? And if so, what's the impairment rating? So when we come to treatment, definitions are just ordinary English definitions. Reasonable means not extreme or excessive. There's a lot of judgment there, I guess. And necessary means required to be done, essential. But I think this is not word that stands alone, because necessary or what, or what. So if you have acute appendicitis, appendectomy is necessary, or you die, or you're gonna have some horrible problems. On the other hand, so I have a chronically dislocated thumb. I could have that operated on. If someone said, if someone asked, is that essential? Is that necessary? Is that medically necessary? Surgeon would probably say, yeah, that's medically necessary. Um, it's been this way for probably 15 years. That really bothered me any. Once in a while, a little sore once in a while. So it's not really necessary, but the word gets used differently in the medical world, I guess. Most of the things that we're dealing with, in my experience, with few exceptions, some important exceptions, but not big numbers of exceptions. Most of the cases we're seeing are elective treatments, which almost by definition, I should have put that here too. Elective kind of means not necessary, but not a bad idea, or something you can do, like a meniscectomy for a meniscus tear, things that are biceps, you get a biceps ruptured, you get a tenodesis. No, it's not really necessary, but it's a reasonable elective procedure. So those are different words, and we always address them kind of together. Causal analysis might be the most difficult thing in well, not just in medicine, in human life in general. Causes and effects, and every probably philosopher who's written a book wrote about cause and effect. So this paper, I think, is a really useful paper, and since I guess you have copies of the slides and all that, so you can find this. This is a Journal of Occupational Environmental Medicine. This was a paper published in 1996 by Phil Harbour, he's a pulmonary occupational medicine and pulmonologist. I don't know the other guy, and they went through how we determine cause and effect in medicine, and they come up with what they called causation analysis heuristics, and I have a list of them here. So as you can see, there's a bunch of, there's 18 of them, and one or two of them have two parts. And so what they are is the strategies or the ideas that we use, the rules, the heuristics is the word they use, that we use to determine cause and effect, whether we know it or not. In some way, we're using some of these tools. And there's an old joke: if you ask two doctors, you'll get three different opinions. And why, if two physicians have the same data, same information, they examine the same individual, why do they come up with a different cause and effect relationship? And it basically depends on which one of these heuristics they're using in their own analysis. And I'm just going to point to a few of them. The first one here is hypothesis testing, and that's what's used in doing scientific research, where you have a p-value and all that. You're doing some research to determine if treatment A is better than treatment B, or what have you. And you're going to say it's true if there's only a very, very small chance that you're going to be wrong. And so this person who's using hypothesis testing is going to be much less likely to find a causal relationship, because he or she wants to be exceedingly sure that he is right, he or she is correct. So hypothesis testing, that's going to lean you toward not a causal relationship. The other one I wanted to point to, number 12. So this is utility weighting, and basically it says benefit of the doubt. If I'm not sure, that's work related. So if you're not sure, and when are we ever sure? Why did I do that? If you're not sure, then you're going to go ahead and say, yes, this is related. The cause is related. The cause and effect relationship is there. So this person is going to be far more likely to find a relationship than is the person up here using hypothesis testing. And then finally, I'll look at number 18 over here. Basically, flip a coin. I don't know. There's no way to know scientifically, so let's just flip a coin. So that person's going to come out 50-50. And then all these other ones in between, some of them are going to come out yes, some of them are going to come out no. And there you go. I think that's why you look at, Dr. Jones says, yes, there's a relationship. Dr. Smith says, no, there's not a relationship. Well, they're looking at it differently. They're using a different tool, a different heuristic. If if like or a state, let's say the state said we're going to use we're going to pick one of these. You have to use this one. You have to use this one or this one. Then everyone's going to be the same. Everyone's going to most likely, there'll probably little outliers and stuff, but it'd be much more likely that everyone's going to agree. But that's not how we do it. Oh, by the way, um, you might say, well, random. Nobody's flipping a coin, but there's an interesting corollary there. Is that when you pick the if you pick randomly who you're going to ask an opinion from, you have flipped a coin. Because you don't know what heuristic that person uses. So kind of no one's I don't think anybody's sitting in their office flipping a coin saying here's how I'm going to decide it. But the process may have already taken place when a case is assigned because that person they don't know what that person's heuristic is going to be. Does that make sense? See, here's again, I don't explain these things that well, I think so. I would ask for a show of hands. You understand what I'm talking about? If not, you can send me an email. So there are some helpful things that we can use. There's some books. So there's this book of that's put out by the AMA, Disease and Injury Causation, and I have it here in my desk here, and it's a big fat book, and it goes through. It's how many pages? 800 pages or so of all different things. Here's your ganglions of the wrist. Are they caused? And it gives tables and tables of the literature, that some literature says yes, some literature says no. You can look at that, all these tables of things, and you can sit there and go through all that, but you're still going to end up going back to what your own method is, I think. And then NIOSH published this book many years ago. I can't remember when that one came out, and it's still useful, I think. But they looked at a lot of different literature and came up with ideas about what causes upper extremity, neck, arm, and lower back work-related musculoskeletal disorders. I think there are some disorders that are accepted just based on the diagnosis. Well, if someone has mesothelioma and they had any kind of exposure to asbestos, then that's a given. I don't think anybody's going to fight about that. And in some jurisdictions, I'm not sure if it's here in Vermont, but in some jurisdictions, firefighters who have a heart attack, that's routine. That's de facto accepted as related to their work. I don't know if we have that in Vermont, but some states do that. So another question that comes up is work capacity or work capability. And this is another interesting area where there's some things that need to be called out or sorted out. So there's several concepts that these guys come up with in this book, Talmadge, and I have that book here somewhere too. That's not as fat as the other one. So one is risk. So risk involves harm to self or others. So when we look at someone going back to work, is there risk? Is there a risk that person's going to harm himself, herself, or somebody else in the workplace or out in the world at large? What's their current ability? What's their strength? What's their flexibility? Things of that nature. And the one we deal with, I think, the most, in my experience anyway, in this setting is tolerance, pain tolerance mostly. That's all I got on that. I thought I had more on that. Maybe we'll come back to that. So then we go to impairment rating. So we have a bunch of books. So here's the AMA guides, my beaten up copy of the AMA guides, 5th edition, which is, I think, when did this come out? I'm going to give you a copy. So this came out in, it's like 2001, 2000, 2000, 5th edition, 2000. So this book is now 20. Yeah, it's 2021. This book is 20 years old, and now the 6th edition is out now, of course. And we decided here in Vermont, for whatever reason, we're not going to use the 6th edition, so we're still using this 5th edition. And at some point, my pages are all falling out. I'm going to need a new one. There's a couple, and typically everything you need is in there, but some of them some impairments aren't as clear cut. So we have these companion guides. We got the medical legal companion, which is produced by this lawyer and goes over the medical legal issues of the guides. And then the guides casebook and master the AMA guides. There's others. There's also the guides newsletter, which if you have a issue difficult, you're looking at the AMA guides, I'm not really sure, you can get guidance from some of these other sources. So most cases that I see, are coming out of 3 chapters: the spine, chapter 15, upper extremities, arm, and the lower extremities. And it says here, I'm saying impairment generally based mainly on objective factors. Not always the case, but that's the ideal. So we're going back to the definitions of impairment and disability. So according to the guides, impairment, we went over this already: loss of use of the derangement of the body part, etc. Disability is the alteration in an individual's capacity for these various activities based on an impairment. A relational outcome depends on what they do. All the example, trite but true example people use. A lot of you hear, like, if I lost my little finger in an accident, I'd have a certain impairment, a few percent or whatever it is for losing a small finger. It wouldn't be a big disability. I have very, very little, if any, disability. The concert pianist, same injury, has the same impairment, but a different disability. And disability impairment is a medical concept. So impairment is, I lost my little finger, my impairment is X percent. Disability is a legal concept, and there's all different definitions. Everybody has a different definition. Social Security, different states, the Americans with Disabilities Act, private insurance companies, the World Health Organization, a lot of different organizations and entities have different ideas or definitions of what disability is. And one way to look at it, I think, is with the Venn diagram. I was going to make a Venn diagram with like 100 of these little boxes, but this is impractical, because in one box you got circle, excuse me, in one circle you got impairment. In the other circle here, you got all these other things. You got the person's general health, you got their mental health, you got motivation, their financial situation, their job satisfaction, personal relationships. Personal relationships in the workplace are extremely important, particularly relationships with supervisors and that sort of thing. So all these other things, and et cetera, may be 100 more things, all contribute to the disability alongside the impairment. And that's why you can have folks who have a huge impairment but very little disability, and other individuals who have a tiny impairment but they have a huge disability, because the factors, all depending on all these other factors that are all playing a role. So we say permanent impairment. We don't consider permanent impairment until the condition is static and well stabilized, maximal medical improvement. And this is really a person who's at maximal medical improvement here. Then otherwise, as it states here, an individual's condition is dynamic. Now, when you read this, how this is defined in the guides, this last sentence here I find interesting, because it says it's a date from which further recovery or deterioration is not anticipated, although over time there may be some expected change. So it seems to be saying to me that we don't expect any change, but we expect some change. Doesn't it read that way? But I think basically what it's getting at is that all of us are aging and we're all going through all these different life changes, that we're not going to see a huge change in the short term in a person's medical problem, but over time things do change. I guess I just said the same thing. We don't expect change, but we're going to expect some change. So short-term change, we're not going to see. The treatment's done. They're not having any more treatment. They're going to maybe have some waxy symptoms. Maybe as they age, things are going to get worse, or maybe as they age, things are going to get better over the long term. And so, again, impairment versus disability. We're doing impairment rating, but it's a rating, comes out of this book. It's not intended for use as a determinant of work disability. They do suggest that the impairments they came up with have some predictive value over the person's daily activity, daily activities of daily living, normal things you're doing, not work activities, which are highly variable and not covered by impairments. So we've looked at impairments, hopefully by measuring, measure joint motion, we can measure muscle function, we can measure nerve function, all that kind of thing. But sometimes we don't find much there, but then there's pain. Because all the pain, I have all this pain. I've only got 5% impairment, but I have all this pain. It's terrible. I can't do anything. That's how the book's written, and the guides say that the impairment ratings already accounted for the pain that's commonly associated with those problems. So here's some wiggle room, because if it's commonly associated pain, fine. But what if my pain is much more than other people that have this condition? So chapter 18 is the pain chapter, and it tells us that you can rate impairment for pain when there's excess pain in the context of a medical condition that does cause pain. So if you have, let's say you have arthritis in your elbow, and it's so much more painful than someone else's arthritis in their elbow. I guess technically you could do it in pain impairment. Uh, when there's well-established pain syndromes that don't have identifiable, objective, measurable things, so migraine headaches, maybe tic-douloureux, things of that nature that there's nothing to measure, but they're very painful, and everybody knows they really exist. And then other associated pain syndromes. Uh, so again, there's things where you don't measure, where the measurable impairments are not really sufficient to explain the person's overall impairment. Now, even still, Chapter 18 allows 0 to 3% whole person impairment for pain, so it's not a huge. It's not a huge. It's not a huge amount. And interestingly, in the category ratings for back pain, neck pain, back pain, and so on, each category allows a range of impairments. So, for example, for low back pain without radiculopathy and so on, you can have 5 to 8%. So they're allowing a 3% difference in impairment depending on the clinical judgment on the individual's problem. So one person with low back pain might get a 5%, so one might get an 8% based on that chapter, the spine chapter. Now, my understanding is that the editors of the two different chapters weren't communicating with each other, and it's just a coincidence that the pain chapter allows an extra 3% impairment in some cases, and so you don't add this if you're doing a diagnosis-related category for back pain. You don't add another 3% to the, like if you gave 8%, well, that's the 3. There's your 3. So that's just a curiosity. We should be using the 6th edition anyway, but don't get me started on that thing. So we have a number of impairments. Suppose we have a number of impairments, and we have to combine them. So once in a while, people have criticized my arithmetic, but when we put impairments together, for the most part, we combine them. There are some caveats about that, but for the most part, we combine them. So, for example, if we have a person who's got a 20% upper extremity impairment and a 15% lower extremity impairment, they might say, oh, I have 35% impairment. Well, not really, because the first 20% taken off for the upper extremity, now we have 80% of a person. So we have 80% of a person left. It's a harsh way to look at it, I guess, but that's kind of, for the math, that's what works. All right, so then we have that person has a lower extremity problem, and we're taking 15%. Well, we're not taking 15% of 100, because remember, now we're at 80%. So we're taking 15% of the 80% of a person, which is 12%. And then we add those two together, so we get 32%. So it's not a huge difference, but as you get up higher and higher, the difference between an addition, a straight addition to a combination becomes bigger. And that's why no one can have more than 100% impairment is dead, and or in a profound coma, and you can't have more than 100% impairment. So if you had your shoulder, your arm amputated at the shoulder, God forbid, then you got that 60% impairment. Then you're bad luck. You got the other shoulder off, and now you, like the guy in Monty Python, and now you got another 60%. Well, you can't have 120% impairment. So if you did the math in your head, you could figure out what it comes out to, and it's pretty high, but it's not 100%. Now, it's simpler than doing these arithmetic. There's a chart in the book, the combined values chart, and it's in fact, I have a little piece of it there, but it's a couple of pages of chart. I can actually show it to you. I can't do this when it's in person, so hopefully, there's one page of the, well, 1 2-page spread. There's more. And then it continues on the next page, and then it goes up to 100. So if you combine, like if you have 99% impairment in one for one injury, and then you get another 99% impairment, that's how you come up with 100%. But then you're probably deceased. All right, so let's move on. If anyone has questions, please don't hesitate. Send me an email. I think my email is, in the book, right? drwhite@ohlogic.com. And that's all I have.